Welcome everyone back to the series of non-interpretive skills in radiology. My name is Nadia Kedem. I'm a neuroradiologist, and today we're going to talk about MRI safety. And I'm joined today by Stephen Mercedes. Stephen, do you want to introduce yourself?
Yes, thank you, Dr. Cato. My name is Stephen Mercedes, as Dr. Cato mentioned. I am a MRI technologist, been doing MRI for 10 years. My title is also Magnetic Resident Safety Officer for a children's hospital. And I've been within radiology for about 12 years altogether, specifying with MRI for the last 10 years.
And I know from working with you that you're a real expert and you've put our MRI safety program into really good shape. I'm so happy to have you here today, Stephen. So we're talking about the different magnetic fields. And is there any difference in the risk related to the field strength of the MRI?
Yeah, so it's very interesting, right? MRI has these three energies that we're really concerned about. You have ultrasound and X-ray, which are relatively simple to understand in the sense of you're shooting something at something and you get something on the other end, whether it's sound waves or ionizing radiation. With MRI, you have these three different energies, which is already just with that makes it really unique, right? You have the static magnetic field, which when you have individuals talking about the magnetic strength, the field strength of the magnet, that is what they're referring to, the static magnetic field. So you have things, open MRIs usually points at 3 Tesla, 1 Tesla, and then you have the higher field strength of 1.5 and 3 Tesla, which are usually the ones in hospitals and even in some research facilities now you have 7 Tesla, as we know, and that is something that is expanding to the clinical space. There are benefits to having higher field strength with certain exams. There are certain exams that you don't want the higher field strength, but for the most part, if you get a higher field strength magnet with especially neuroradiology, you're going to get somewhat of a clearer image.
Yeah, that's glad you mentioned that because we do think more is better. But in terms of the field strength for MRI, what I know about 7 Tesla imaging is that it's very susceptible to motion artifact and any middle artifact. So even though the resolution can be higher or the scan pace can be faster, there are those trade-offs. What are generally the risks that you're concerned about with MRI?
So because there's those three different energies, there are three separate categories of risks. When I look at a patient who has an implant, for example, or just someone going into the room, I address each of those concerns through each of those categories. So the first is the static magnetic field, which is always on. That is what never turns off. And if it is turned off, it's through the process of the quench, which I'm sure we'll touch on a little bit. But static magnetic field concerns are translational and torque forces. So if something is strongly ferromagnetic, meaning it's going to be very much attracted to the magnet, those are the first things that I address. Is it something that's going to be pulled over to the machine? That addresses the static magnetic field. Then you have the radio frequency energy. Radio frequency and gradient energies are turned on during the active scanning. Those concerns are more so regarding heating and also electromagnetic voltages going through, especially through the gradient field. So those are the three concerns. I always try to look at them and break those up with, are they going to be in the RF and gradient energy in that area of being scanned? The static magnetic field is something that's always going to be on. So if it crosses that one and it's a concern for that, I don't even move forward with it because it's something that it crosses off the list. So that's how I address it.
Okay, great. And we will talk about these three issues in a little bit more detail later. I wanted to briefly touch on the system that we have in place for MRI safety. I think it's mandated to have a really firm roles and leadership structure in the department. So you're part of it as the MR safety officer, MRSO. And there's also a medical director and an MR safety expert. Who are those people? How do you work with those people?
Yeah, so those three roles together make up the MRI safety team. And then you can always add to those, but those are the core center of the MRI safety team, the MRMD, the MRSE, who is usually a physicist in the roles of physicists. And they are really great with being a resource to their expertise, especially when it comes to the protocols and scanning. And then my role of MRSO, which really takes care of the day-to-day things that MRMD and MRSE wouldn't be able to take care of, being present on actual everyday implants that come through. And as we know, there are implants coming out. It seems like every day. So
Yeah.
the day to day is really what the MRSO and their role is concerned of. And then when it comes to policies and procedures, those three roles come together, discuss.
Perfect. And I think the physicists are able to also give advice or create protocols for conditional devices to meet those requirements. And we'll talk about that in a moment. And
Definitely.
the other mainstay of MRI safety is that zoning in MRI. Those are actually popular board questions on the radiologist board exam. What is zone 1, 2, 3, 4? I always have a hard time remembering. Can you talk a little bit about these zones and why we've implemented that system?
Yeah, yeah, that's great to know. The zoning starts from 1 to 4. I try to think about it as the degree of burns, right? Zone 1 is really just the general public access area. And anywhere within the hospital is zone 1, essentially, and everywhere outside of MRI department. Zone 2, I usually categorize that as the first place where you're introduced to MRI, whether that be a check-in desk, some changing rooms are in zone 2. So this area can be restricted, and actually the new ACR guidelines recommends that there is some sort of supervision in that area, but that is zone 2. Zone 3 is where the update from the lax manual in 2020 to this one, because there's also so many things that can go through zone 3. In zone 3 is usually where the control room is. This is where a lot of the last final checks and safety timeouts are performed before going into zone 4, which is the scan room. So the biggest change is from zone 2 to zone 3. This is because zone 3 is pretty much treated like zone 4 in the scan room because there's easily accessible doors to the scan room. Some places don't have keypads, some places don't have badge access to zone 4. So zone 3 is treated as zone 4. So if there's any screening that needs to be done, questions, wanding, going through any ferromagnetic detector systems, usually done in zones 2.
All right. Yeah, that was my next question because it seems to me so difficult to manage who's going into which zone and out, and what do they do about MRI? Do they know where they're allowed to go, what they're allowed to bring in the zone? Are there changing areas where people can hang up their doctor's coat with all the electromagnetic items that they might have in their pockets, scissors and reflex hammers, things like that? How do you manage that?
Yeah, that gets tricky. And if you can imagine, especially at a children's hospital where you have a lot of different moving parts, right? You have sedation physicians, you have anesthesia, which in an adult hospital, you're not used to seeing. Usually, MRI department is tucked away in a basement and no one ever goes there, right? They don't even want to go there. So it's a little different with a children's hospital because you have so much flow of traffic. We usually have bins outside of zones 2 where those ferromagnetic objects, phones, wallets, because obviously we know that the credit cards will get wiped, just scissors, anything like that gets placed into that basket. And it's one of those that if you're going to go into zone 3 with it, you have to take it and hold on to it and place it in a specific section. There's also methods of tethering, whether that be by a charger. Usually, if you have your phone, and a lot of physicians need their phone and nurses as well to communicate with the floors, there's a charging station where you keep the phone tethered because I can't begin to tell you how easy it is to just take your phone, slip it in your pocket, and totally forget, right? But then an emergency happens with the patient in zone 4. You're not thinking about what's in your pocket. You're just trying to act in that moment. That's why, again, everything that we try to do and really put an emphasis on that is to be done in zone 2, because once you're in zone 3, it can get really tricky with trying to last minute try to figure things out.
And what is this idea of having level 1 and level 2 personnel in the MRI area?
Yeah, great question. So, level 1 personnel are those who have regular assignments in zones 3 and 4. On my role at a children's hospital, it's really more so sedation nurses, anesthesia, who are there regularly, right? At a general hospital adult facility, this will probably be those nurses that are on the floor that bring patients down frequently. I know that I've worked at another institution to where if there was an ICU patient that needed to come down, they had assigned teams that said, hey, they're familiar with MRI. They're going to be the ones to go. Those were the level 1 personnel. Level 2 now is more so referring to the technologists, the MRSEs, the MRMD, and the radiologists. The radiologists really because we consult with them to clear patients. So anyone who is involved in the screening process to clear patients, those are level 2 personnel. Now, the new ACR recommendations, they really dug further and decided to go a little surgical with the dissecting of what's level one and level two. And they said that now with stratification of roles, and they understand that there's a bunch of different environments that you can have a level 1B or level 2A, level 2B, depending on your environment. So that can be adjusted according to the institution's policies and practices.
Okay, great. It seems like they're just making it more and more complicated, but it is a very complicated environment. And
It
I'm
is.
sure some of the physicians or the staff that go into this area fairly frequently are unhappy with all the screening that they have to do, but it's just really necessary because we have so many incidents. They're not very frequent, but when they happen, they can be very severe. Sometimes we see these pictures of the internet with a chair that has gone into some magnet bore and it destroys the magnet bore. And also, you have to shut down that scanner for a time and get repair on place. Even like small paper clips, when they come in the scanner and they get trapped, they can cause artifacts on the images. And sometimes you have to dismantle the scanner to some degree, right?
Absolutely. And I'd say that these things happen more frequent than we think, right? When you have an organization, and it depends on where they prioritize MRI safety. If there are ones who strongly prioritize MRI safety, the chances are that safety events are being reported and things like this, everything is being reported. But at an institution where it's a little bit more laxed, I'd argue that things happen very frequently and not getting reported, obviously. Once somebody works in the MRI environment, they're familiar with what is strongly ferromagnetic and what is not. Something like a paper clip and getting stuck to the machine is something that they'll just take off and keep going until there's an issue with, like you mentioned, artifacts. And now it's let's bring the machine down for a day. They have to run testing, come to find out there's some paper clips within the bore lining, which I'm saying that and it has happened. So all of these things are things that occur on a daily basis, but we're working on reporting them a little bit more and just working on the whole process. And I think that the ACR noticed that these things are frequent, which is why they decided to go a little bit more in detail and address these things.
Perfect. And then the other question I have is in the MRI area, you have to have emergent equipment for when there's a code blue or even anesthesia. They have to have the equipment in the scanner room to some degree. How is that managed with regards to the magnetic components?
Yeah. And that's something that if you don't know, you don't know. A lot of the people that are in the MRI environment assume that whatever's in the room is safe. And that's where we briefly mentioned it earlier. That's where we have the categorization of safe, conditional, and unsafe. Unsafe, it's not going into the room. MRI conditional is where a lot of our equipment, even the MRI scan tape, the one that actually docked onto the table, is labeled as conditional. The reason is because if you put it through a ferromagnetic detector, it will alarm because there's little no bolts and screws that are well embedded in there, but they are there. So it's not MRI necessarily MRI safe unless it's totally plastic. So going back to your question of anesthesia machines, there, if you take one of the 1,000 Gauss magnets that we have in the department to test different equipment, there's a part, different parts actually within the anesthesia machine that if you put that there, it'll be tough to remove it from how strongly ferromagnetic it is. When it comes to that, that's where we have these Gauss lines in the rooms. On the floor, a lot of the times, the physicists are actually the ones who mark these lines by the measurement. And it's just measuring the static magnetic field. And they allow you to know how far the anesthesia machine can get to the machine. Even things that are in the room. We have a respiratory ventilator that's MRI conditional. But if you get that thing too close to the machine, it's going to get stuck on there. And that's where we have to ramp it down, call the field service engineer because it's going to be very difficult to pull those things off. Yes, back to your point, there's a bunch of equipment in the room and outside in zone 3, even that's conditional. That doesn't necessarily mean that you can go into the room as far as you can and close to the floor.
And I remember in the past, I don't know if this is still how we do it, but when I was at a different place, this is the 5 Gauss line that you're referring to. And there was some equipment that could go in the room and it would have to be bolted to the floor outside of the 5 Gauss line so that it was impossible to move it beyond that line. But then you could store certain equipment in that device.
Definitely. And then going back to the tethering that we have in zone 3 with the phones and the people avoiding for it to putting in the pockets, we have tethering inside of zone 4. We
Oh,
have plastic chains and ropes tied to the wall and tied to the machine so that when it's fully extended, it really only goes as far as that 5 Gauss line. Obviously, human error can slip into that and people can unloop it or do something like that. But again, going through all these measures to try to avoid all of that from happening.
Great. Thank you. So we have experts like you, we have the zoning, and then the other thing that we do for safety is screening, right? We really do very extensive screening in MRI. Can you talk a little bit about the screening process?
Definitely. That is, I'd say, the first contact that we have with the patients. As MRI technologists, nurses on the floor, this is the first step to knowing if this patient can be scanned. Usually, this is a bunch of questions, and the ACR has the link recommended to their website to where they have, I want to say it's like a 7-page screening form.
Oh,
A lot,
wow.
I don't know any place that I've worked at that 7-page screening form, but it really goes down to the details. A lot of places have 1 or maybe 2 forms regarding screening, but all you really want to do is make sure that the individual that you're going to have going into the room, whether it's the patient or a family member going in there, or even a staff member, right, that they don't have anything implanted in the body. That's one of the things that a lot of technologists usually ask is, do you have anything in your body that you weren't born with? No original parts. That's what we look for, right? That, as well as any injury where something could have gotten embedded in the skin. And now you even have issues with the clothing. This is more specific to those patients who are going to be scanned. All patients who are going to be scanned should be changed into something, the hospital scrubs or gown, because we've had incidents of people getting burned. That's from that RF energy, right? Those people inside the scanner getting burned. So again, even going down to changing clothes, all of these things should be addressed on the screening form. And I can't tell you how many times I've seen those screening forms with just lines going down. And this is one thing that actually Dr. Emmanuel Canal from University of Pittsburgh, he had mentioned. He said, that's not going to hold up in a court of law. I try to always stress that to the technologist, make sure each box is checked.
Yeah, and I think it's important because even when you ask people, do you have any implants? Sometimes they just forget. They had that thing for whatever, and they're just forgetting that they have it. And it's good to ask specifically for specific things. Or they forget that they have a big tattoo on their back and they didn't think that this could be something they should mention. So yeah,
Absolutely.
definitely a good value to ask those questions. And then I think we have like metal detectors and wands. Do they play a role in the screening process?
Definitely. So the screening forms are that first check off, right? That's that first part. And like you said, I can't tell you how many times people have forgotten, or maybe they're misinformed, right? I know that I've had a situation where a patient said, no, I have no metal inside my body. I had a stimulator, I had a pacemaker, and it was removed. What a lot of the surgeons don't tell them is that, yes, they removed the generator, but the leads a lot of the times remain in the body. But this is a patient who's not familiar with the medical field and they forgets all the time. So after that, we move on to the wanding. I always try to explain to the patients and the parents and family members that want them, similar to the TSA, get nice and close. It recommends being skin close, so it may be a little uncomfortable, but this is another step. And then we have the screeners, which is one of those, they stand on the walls, you spin, and it detects if and where there is something in the body. That's probably the most accurate because the wanding is more so you can have human error. The screeners are excellent. I'll tell you, we had a situation where a patient came in, child, he had swallowed something, parent did not know. And again, everything is no on the form. No, there's nothing in there. The screener just kept going off. Well, come to find out, they did some x-rays and did find out that the patient had ingested something. So that is the most accurate. And then on this last line of defense, which really is not too, people should not depend on it, is the ferromagnetic detectors around the doors of zone 4. So this is really just more so for equipment purposes, but as a screener for a patient who has something inside their body, this is just the very last check before going into zone 4. Yes.
Yeah. I do remember where the patient had been screened and cleared, and they had to wait 10 minutes. And during those 10 minutes, they whizzed out the phone and they watched some videos and then put that in their pocket. And it was caught at the door for the MRI scanner. So, yeah, the last resort, like you said, that it's
Happens
there.
often. Yes.
We're taking a break here. Tune in to our next podcast to learn more.